Hello, my name is Farhad Safezi. I'm an ophthalmic surgeon and a clinical researcher, and I was part of the team that established cross-linking technology into ophthalmology. In, in this talk, I would like to give you an overview about what we call the ELZA recommendations for cross-linking 2016. The reason I'm giving these recommendations, which are based on my very personal assessment of the current state-of-the-art technology, is the fact that on many congresses and conferences, I'm repeatedly asked to give my opinion on new techniques like iontophoresis, epithelium on cross-linking, pixel, etc. All these new techniques and protocols that emerge and that sometimes might lead to a certain confusion with the user and the customer, the ophthalmic surgeon, because of the high dynamics in this field and the fact that new protocols come up multiple times a year. So this is the update Q1 2016, and please make sure to come back and check our website for the update Q2, which will come out in April-May 2016. If you're interested, subscribe to our newsletter and we will keep you posted. These are my financial disclosures. And whenever looking at a new technique, I asked myself, is this based on science and clinical evidence, or is it based on wishful thinking, marketing? So what we need is a raster into which we put a new technique and assess whether the body of evidence given in laboratory science investigations or in clinical trials is strong enough to support the new protocol or the new technique. And sometimes you will see techniques that have a very high level of evidence for both clinics and lab, so they are recommended. Others might be the exact contrary, and I would not recommend them at all. And then you have these very interesting borderline cases, which might be fascinating new concepts that have not full clinical validation yet. And it's in your own, very own risk and responsibility if you use them on patients already. Again, this might be an off-label use of an established technique, but you just have to be sure that you perfectly know as the treating ophthalmologist that you're dealing with a new protocol that has not full clinical validation yet. So these would be the borderline cases. Now, this is a big list, but certainly not an exhaustive list of current indications and modifications of techniques. And what I tried to do for myself a year back was to put them into the scheme to better understand where most of them would stand. Epithelium of cross-linking certainly has the greatest body of evidence in cross-linking technology. It's been there for more than 15 years, and this is why you will find it in the upper right corner of the green rectangle, which means recommended, high body of lab science, high evidence body of clinical sciences. Accelerated cross-linking, as long as you do not accelerate above 9 milliwatts for 10 minutes, also seems to be very reliable, and there is a large number of papers out there that support this claim. PUC cross-linking, on the other hand, for infectious keratitis has some encouraging laboratory evidence, but still very little clinical evidence. So it barely still is in the green rectangle. It might move into the upper right corner someday, but as for now, I would recommend it only in selected cases, and this is by far not a routine procedure. Epithelium on cross-linking has been heavily propagated, but has been rather disappointing because although the laboratory evidence might be good, clinical evidence is lacking solid results, and the failure rate is unacceptably high. Cross-linking for sterile melting, again, has a solid body of evidence. The first paper was published almost 16 years ago and is increasingly used for this indication. Bullous keratopathy, on the other hand, is rather disappointing. There is a little bit of laboratory evidence, a little more for the clinical part, but it certainly cannot delay the time course of a cornea guttata. It might help in the perception of pain related to the bulla in bullous keratopathy. Cross-linking and PRK, whether you call it the Athens Protocol or not, also has a quite solid body of evidence. I would recommend it, but you have to be sure that you understand the different concepts of simultaneous or sequential treatment, and you have to be very careful not to remove too much tissue or you will reactivate the ectasia. Cross-linking in intrastromal rings still need quite a bit of workup, but both methods are clinically established, so it's in the green recommended rectangle, but we still need to better understand how these techniques work together. What is not recommended as per now is to use, in my personal opinion, is to use cross-linking to prevent ectasia after refractive laser surgery. The reason is simply that ectasia after LASIK has such a rare occurrence, 1 in 5 to 1 in 10,000, and I do not see any necessity to perform 5 to 10,000 procedures to prevent one single complication to occur. And there has been no clinical study performed yet to support this claim of preventing ectasia with cross-linking. Also, the study would need such a high N that it is almost impossible to conduct. Conductive keratoplasty and cross-linking has been published and cross-linking does not stop the regression of the induced changes that are triggered by conductive keratoplasty. And cross-linking as a standalone refractive procedure might be a fascinating experimental concept, but I would definitely not use it yet in clinical practice because the amount of refractive correction still is too unpredictable. Accelerated cross-linking over 9 milliwatts per square centimeter is something that I would not do in my patients, as well as pulse cross-linking, because the results have been rather disappointing both on the laboratory evidence side as on the clinical side. Iontophoresis has mixed reviews because newer techniques for sure allow more riboflavin intake into the cornea, but it was our group that has shown 3 years ago that there is another additional essential component for cross-linking, which is oxygen. So even if you get a lot of riboflavin into this cornea, the intact epithelium will prevent a rapid oxygen diffusion and will limit the biomechanical process. So iontophoresis, as for now, with the clinical settings and the technical parameters used now, still needs clinical validation. TMD, or Terence marginal degeneration, is another fascinating new concept for cross-linking, but as per now there has only been one single case report with a bilateral application. However, this bilateral application and with a follow-up of 5 years has led to a thickening of the peripheral cornea in this TMD patient, and to our knowledge, a thickening in peripheral thinning disease has never been observed spontaneously before. So this is certainly something worthwhile looking into. I hope that there will be other groups besides ours that will pick up TMD as a research area, because we need higher numbers of cases. And then we have contact lens assisted cross-linking, which is a very good idea, but still has might have quite a few glitches because the oxygen availability will be altered. So you may use it, but be careful about oxygen availability. CXL to stabilize refractive results after LASIK might be a good idea. Makes sense from the conceptually for high hyperopes or maybe even high myopes, but we still need clinical validation. Pulsed cross-linking, and our group has shown this clearly. This paper is in press. Pulsed cross-linking does not give any advantage in the biomechanical stiffening effect of cross-linking. Customized CXL, so topography-guided CXL, again, is a very interesting concept, but not in the clinical routine yet. And stabilized results in high ametropes might be treated similarly to stabilizing refractive results after LASIK. And the last topic, still is pure science fiction, which is scleral cross-linking to prevent progressive myopia. This is many years away from clinical application, but certainly a fascinating field of research. I hope that you liked this overview. As I said, these ELZA recommendations will be updated regularly, roughly every 3 months, and we will let you know via our newsletter once the update is available. You may also contact us in case you have particular questions via info@elza-institute.com. This is Farhad Hafezi from Zurich, Switzerland. Thank you for your attention, and I wish you all the success with your cross-linking applications.